Welcome to the latest edition of the ClearPoint TV peer-to-peer webinar. I'm David Franco, the General Manager of Laser Therapies for ClearPoint Neuro. We're pleased to have today Dr. Veronica Chiang. She'll be talking about how she uses ClearPoint in surgery for patients with brain tumor. Dr. Chiang has joint appointments in the departments of Neurosurgery and Radiation Oncology and leads the brain metastasis program at the Yale School of Medicine. She specializes in neurosurgical and radiosurgical management of brain metastases, as well as post-radiosurgery complications. She's known nationally and internationally for her research on the clinical and radiological outcomes of the multidisciplinary management of brain metastases and radiation necrosis. She's been a leader in using the ClearPoint system as a cornerstone of her surgical navigation, and she'll discuss these methods now. I'll hand it to you, Dr. Chiang.
All right. Good afternoon, everybody. Thank you so much, David, for that nice introduction. And thank you to ClearPoint for the opportunity for me to talk with you about where the ClearPoint device actually fits into my practice. Whoops, sorry. My disclaimer. All right. And so my practice is predominantly involves the management of brain metastases patients. And over the course of my career, it's been interesting to see the changes that have occurred. So starting in the 1990s, the patient population that developed brain metastases were predominantly symptomatic. The disease was, the brain mets were found late in their disease, and their treatment was mostly evolving around whole brain radiation therapy, the occasional patient getting surgery if you had a single metastasis. And so as you all know, the survival range was somewhere between 3 and 10 months, with the 10 months being kind of those that had a single metastasis and got whole brain radiation therapy to follow. The following decade, we started imaging surveillance. And so this really changed dramatically the patient metastasis population. And so they went from predominantly symptomatic to predominantly asymptomatic. And the tool known as radiosurgery came into development. And so the goal here with these patients was to take care of them, to keep them from developing symptoms. But really, we didn't make a huge impact on their survival. The last decade has shown an exponential rise in the use of radiosurgery as whole brain has waned. But what really has changed in the past decade is that systemic therapies, including targeted therapies and immunotherapies, have really improved survival in the patient. And so our goals are still to try and keep them asymptomatic, but the challenge is increasing. And so what is coming with the upcoming decade? And I think this is where we're going to get so much better at treating cancer in the body that brain metastasis is going to be one of the remaining challenges in taking care of the cancer patient. And so our goals remain to try and keep the patient asymptomatic and preserve their quality of life. But I think it's going to become a busy decade for us. And so this slide just highlights the fact that with the waning interest in whole brain radiation therapy, radiosurgery has become first, second, and third line treatment for brain metastases, especially since in the short term particularly, radiosurgery has good control of brain metastases. The problem though is that as we treat an increasing number of brain metastases with radiosurgery, we are also seeing an increasing number of brain metastases regrow after radiosurgery, particularly as these patients live longer. And as you all know, the differential diagnosis includes either tumor regrowth or radiation necrosis. And the challenges that remain are that differentiating the two diagnoses remains imperfect by imaging, and so biopsy is often needed for diagnosis. And that the options that were initially available for management were either craniotomy or repeat radiation, depending on your pathology. And so this is one of the cases earlier in my practice. This was a 50-year-old lady with known diagnosis of non-small cell lung cancer, metastatic to bones and adrenal. She was found on her staging MRI to have this single brain metastasis. It was clearly asymptomatic, and she was treated with single fraction radiosurgery with 20 gray to the 50% isodose line. And you can see at 6 months, she had a really nice response to the treatment. Oh, I'm so sorry. But at 18 months, and so obviously living longer than the estimated 10 months survival back in the day, she had a significant regrowth of the lesion. And so not only was there some concern about the diagnosis being incorrect, but also we didn't have too many tools available to treat this. And so she underwent a craniotomy. And so what you can see is that postoperatively, she developed a medial occipital stroke. And so she was left with, she went from being asymptomatic to having a homonymous hemianopsia, which she still lives with today, since she has done very well with her lung cancer. At the other end of the spectrum is this patient. So she was a 30-year-old lady with ER/PR and HER2 positive breast cancer. So somebody who we might expect should have long survival. She had 7 of these tiny little lesions in her brain. And back in the day, the teaching at the time was that if you had more than 4 brain metastases, that you should undergo radiosurgery for the lesions followed by whole brain radiation therapy. And that's what she got. Unfortunately, within the year following, you can see that lesions started to regrow in the area. Given the concern about what this was, it was observed. And so you can see in this middle slide here that the lesions continued to grow. And at this point, unfortunately, when she went to go see her local neurosurgeon with stage 4 breast cancer, it was decided that there was too much morbidity associated with resecting this. So instead, she underwent hyperfractionated radiation. And you can see that this lesion never got better. It in fact got worse. A lot of edema, and by the time she came to see me, she was having a lot of trouble with speech and really wasn't moving her contralateral side. And the interesting thing was that the PET scan, as you can see, suggests that it should be tumor, as does the MR spectroscopy. And when we resected this lesion, unfortunately, it was all radiation necrosis. And so these are a couple of those Sentinel cases that kind of drove me to want to try and find something a little bit more minimally invasive and perhaps less morbid to try and help these patients with this problem. And so I got really lucky, and around that time, our hospital built 2 intraoperative MRI suites. And so that's really what allowed me to move forward with developing new tools. And so many of you have heard me talk about the LITT procedure, which stands for laser interstitial thermal therapy, and basically just means using the laser in the brain to heat lesions for ablation. And so for those of you that are not familiar with the LITT procedure, it starts off with us drilling stereotactically a 3 millimeter access hole through the skull, through a 5 millimeter skin incision. A biopsy is then done stereotactically through this access hole. The biopsy needle can then be removed, and then the laser fiber can be placed. The patient is then placed into the MRI, and the placement of the laser is then confirmed by MR imaging. What happens next is that we turn on the MRI and the laser. And so what you're seeing here is these 3 lines of the MR monitoring lines, the blue line being the outline of the tumor. And what you can see here is a growing yellow line, which is the heat being delivered from the laser. And obviously you turn off the laser when the heating line exceeds the size of the lesion. And so for the patient, this is a really nice procedure. It results in a very small incision. So you can see here, this is actually twice as many staples as we normally put in for an incision for the laser. And you can see the prior craniotomy incision from a prior encounter. These patients can usually go home post-op day number 1, and and many of them go back to their normal lives about a week later, and they can often come off steroids very quickly. And so because of this, the laser has become an increasingly popular tool in those who have access to an MRI for operative use. And so just to show you, obviously, we had a really good initial result. This was a 76-year-old lady who had lung cancer. The lesion was treated a year prior, and then it started to regrow. She developed dizziness and some gait instability. And so here's the laser in the lesion. Here's the post-laser ablation. And so it's even with the tools that we had back then, this is very possible, and she had a nice response. And so across the nation now, we've been able to demonstrate, as shown in this largest study on LITT by Manmeet Ahluwalia and his group, that across the board, if you treat lesions regrowing after radiosurgery with laser, that there's about an 86% survival at 3 months and about a 70% survival at 6 months, which I think is pretty good for this patient population. Unfortunately, what drives success, some of it is pathology. So obviously we do a lot better with radiation necrosis than we do with tumor. But the other thing that drives success is completeness of ablation. And so you can see here that when we totally ablate a radiation necrosis lesion, we can actually get the lesion to go away. Whereas if we subtotally ablate the lesion, we can still get a response or stabilization, but obviously nowhere near as good as complete ablation. For tumor, it's even worse. So if you completely ablate the lesion, the majority of patients will do fine. But if you don't completely ablate the lesion, then actually you get significant failure. And so what's important to note is that we are operating on patients who have already failed first-line treatment for brain metastases. And so it gets a lot more complicated if you fail the second time round, because repeat radiation and other CNS penetrating drugs are less available to help with this scenario. And so how do you get complete ablation? Well, so we've done we've done two things. The first is that we've erred towards offering LITT earlier. And so this is an example of a patient with melanoma who had several lesions treated. You can see this lesion here. It actually shrank and then regrew, and you can see the amount of edema around it as evidenced here. And so clearly this patient is asymptomatic at this time, but what we've learned in our institution is that if you are on immunotherapy and your lesions start to regrow, that this situation does not get better on its own. And so by offering treatment early in the form of LITT, you can see there was this is the lesion after treatment. The edema is stabilized. This patient went home post-operative day number 1. This person only ever got 1 single dose of steroids in the perioperative period. The pathology was radiation necrosis. And you can see that she went on to 12 months of uninterrupted immunotherapy. And so if you can catch the lesions early, that's great. But the other thing that's essential is the need for accuracy in getting the lesion. And so this is my in-house setup that we have for navigation. We use the Brain Lab. We have this articulated arm that attaches to a guidance device with the stereotactic needle. And what you can see on the bottom is the kind of degree of error that I can create for myself. And so that may be a user error, but certainly my ability to line up trajectory is limited. So this is me with the Brain Lab balls facing the camera. This rotated 45 degrees in one direction and 45 degrees in the other direction. And so as the needle and the ball slip around in my hands, my ability to kind of get trajectory 100% accurate can be limited. And so this is what happens when you don't quite get it right. And so you can see here, this was a tiny lesion that we wanted to treat, and somehow we managed to end up in the wrong place. Similarly, a deep, smaller lesion that we tried to get. And so what happens is that you end up having to burn a much larger area, and sometimes even with the larger area, you might not get complete ablation of the lesion. In addition, this also applies for larger and deep lesions. And so we spent a fair amount of time planning to make sure that the entire lesion is within the area of our potential laser ablation, using a cone to predict this. And so the reason for this is that if you have a larger lesion, it's really important that the laser come down right down through the middle of the lesion, so that the radial heat diffusion can spread equally on either side and allow for a complete ablation. And so this is just a pictorial view of that. You know, if the blue is the intended target, then the goal is to get the same ablation heat diffusion around the lesion. If you're a couple millimeters off from the midline, though, you can end up with either ending up with a subtotal ablation because you're trying to avoid critical structures outside the lesion, or you can subtotally ablate because you just literally can't get the heat to the edge of the lesion. And so you can see this is what happened in this case. So we spent a lot of time planning this trajectory. And then as we placed the laser, we ended up too high. And so we ended up with a really nice ablation on the top end, kind of so-so ablation in the middle, and we completely missed it on the bottom. And so luckily this was radiation necrosis. And so, you know, the lesional growth didn't continue. But if this were tumor, we would have completely failed with treatment here. And so I think this is, for this accuracy part of it, I think that this is really where ClearPoint has really come in for me. I think that I chose to use ClearPoint because, first of all, it was available in my institution. And there was a really nice synergy between the Monteris and ClearPoint systems. But part of learning to use the ClearPoint system was that ClearPoint, when it was originally brought into our institution, was brought in for DBS. And as you can see, a lot of their systems, just like with Monteris in the early days, the trajectories were supposed to be, you know, the patient's supposed to be supine. The trajectories were supposed to come out of the bore like this. And you can see similar kind of design with the DBS. And unfortunately, this works really not so well with the tumor patient, where the lesions are not always in the middle of the head, and the trajectories are odd. And so what I wanted to do was, walk through some of my workflow that I do. So one of the nicest things that I like about ClearPoint is this planning platform. So we start at the beginning of the day. This is a recent case that we did with kind of a relatively deeper lesion. So we start at the beginning of the day, kind of potentially picking a bunch of different trajectories. And not only do I like to see, you know, how it passes through the brain and the lesion, but also how it comes out of the skull to kind of give me an idea of what might be achievable and what might not. In addition, I like to be able to scroll through the inline to make sure that not only is our trajectory good, but also that our entry sites are obviously clear, so that we don't end up causing any vascular injury on our way in. And so you can see that of the two trajectories, we decided to pick this frontal one because positioning would be easier for the patient and allowed us to get down the long axis of the lesion. And so the last thing that I've learned over the years is that there's what's called a sweet spot in the MRI, and so that's usually right in the middle of your bore, and that's where imaging is best, both for laser thermocoagulation as well as for alignment, etc. And so what's most important is that, in fact, that you get your lesion into the middle of the sweet spot. And so if this is the bore of the magnet, then the limits with doing this in an intraoperative setting is that not only do you have to get the head holder and the coil and anything else that you've got in within the bore, but then the lesion, or where you think the lesion might be, needs to be close to the center of the bore. And then in addition to that, anything that's going to be sticking out from the head needs to fit in the bore as well. All right. And so what I really like is this view in the ClearPoint system that allows me really to kind of truly estimate where the laser is going to be sticking out, so that I can position the patient appropriately. All right, and so then the next step is for us to place the frame for alignment. And so obviously it's been a bit tricky in the past, but the new array that's coming out from ClearPoint allows us to use our in-house brain lab in conjunction with ClearPoint, so that we can quickly align the frame to where we need to go. And so you can see here that based on our planning, this is the placement of the frame, and then makes it easy for us to work out how the arms fit into the magnet. And so after alignment, we then drill. And so we did not previously have a drill platform for laser. And so ClearPoint allowed us, so I did a lot of it freehand initially, but using the ClearPoint base and frame really allows me to use it as a drill platform. In our institution, we have nicknamed this first generation platform Lucy, because what can happen is that if you use this, it can wiggle around because the material that it's made of is flexible. And so what we've learned over the years is that if we're going to drill through this, that I make sure whoever's drilling come down this bore very, very cleanly, so that there's no pressure on it. And then I hold down here on the bottom of the cannula to make sure that there's no deviation also. And so with many of our trajectories, they are rarely perpendicular to the skull. And so if we're going to pick a non-perpendicular trajectory, then the suggestion is to use a small anti-skiving drill bit, which ClearPoint has, first to create a pilot hole, and then to go ahead and drill the bigger hole subsequently. And so you can see that, so we go ahead and drill the hole, place the bolt, and then we go ahead and take the tower off, leave the base on while we do the laser. And so leaving the base on allows us, if anything's wrong with placement of the laser, to go back and put the tower back on if we need to make adjustments. And so as you can see, ever since I've used ClearPoint together with Monteris, it has really allowed us to get very, very good accuracy with our laser trajectories. And I think that that has really allowed us to be more successful with complete ablation of our lesions. And so as I added ClearPoint to the laser procedure, my very vocal colleagues around me would ask, why do we still keep doing this? It takes so much longer than a standard craniotomy. But I do think, and hopefully in the next couple of cases, show you what we've been able to achieve. I think that with practice, we've gotten faster with being able to use the two systems together. And we can do things that are complex, perhaps better, I think, than with an open craniotomy. And so this first case is a poor, unfortunate patient with pancreatic cancer. He had systemic metastases, but had never developed any brain metastases. Came in with horrible headaches from all the edema in his head. But his primary medical oncologist insisted that there was no way that pancreatic cancer went to the brain. And so we were forced to perform a biopsy to get pathology to prove that that's what we were treating. And so One of the nicest things about ClearPoint, I think, in our brain metastasis patient population is that that biopsy can be done through a 5mm scalp incision. And so obviously we can target any of these lesions with pretty easily. But with a 5mm skin incision, it means that we started whole brain radiation therapy 3 days post-op, as opposed to the standard 2 weeks that we would wait for the incision to heal. And so a lot of our biopsies are done now with the ClearPoint so that the radiation guys don't have to worry about our incisions as they make plans for radiation. The other thing that's nice about the ClearPoint for biopsy is that they make a ceramic stylet that allows us to image exactly where we are in the operating room. And so I'm sure many of you know or have done this where you've tried to do a stereotactic biopsy and the pathologist comes back and says reactive change or you're close, but we don't have definitive pathology. And the problem with that situation is that it's very hard to know if you are in fact in the lesion and that is the pathology, or in fact, have you missed your target and you are indeed close but not there yet. And so this was a 67-year-old patient who had developed a base of skull lesion that grew up into the petrous apex and then into the anterior brainstem. And so I obviously biopsying this lesion gave me significant angst. What using the ClearPoint allowed me to do was, first of all, obviously to plan the trajectory, but then to be able to pass the ceramic stylet halfway down so that we could check before we actually passed it all the way into the brainstem to make sure we were absolutely on track. And then also to pass it all the way down to show that we were in the lesion when we got the biopsy. And so this is particularly important for me with the radiation necrosis patients because obviously the radiation necrosis diagnosis is usually made with the exclusion of cancer. And so obviously if you get cancer cells when you do the biopsy, you know you're in the right place. If you don't get cancer cells when you do the biopsy though, it's hard to know if you just missed the lesion. And so many of my radiation necrosis biopsies now we do with the ClearPoint. And so I get the biopsy, I then place the ceramic stylet, I get the MR to demonstrate that I was actually in the lesion. And then there's no discussion about where the biopsy came from. I also wanted to show you that I think that there's a fair amount of flexibility within the ClearPoint system as well, which allows us to use it kind of as our single navigation platform. So this is a gentleman who actually had squamous cell carcinoma of the face that extended posteriorly up into the skull base. And he developed this lesion, which actually is radiation necrosis from the extensive amount of radiation that he had. And so to laser this lesion, you can see actually how extreme the trajectory has to be. You can see that its angle relative to the surface of the skull is quite angled. And when I first started, I wasn't sure that we were able to do this. But you can see that we're actually able to achieve this. So this was the position we ended up in. And so you can see here that we are rolled all the way posteriorly. And so what we've learned is that if you take the roll-lock screw, which your rep will never tell you to do, but if you take the roll-lock screw out and turn the roll and pitch both as far as you can go, you can actually achieve greater than 50 degrees to the vertical, which allows you to get that oblique angle. And so you can see here, you know, we obviously were able to plan this, get the arms in, and you can see how oblique the angle is of the bolt relative to the base. And so it's allowed us to do cases like this as well. This was a lady with NF2 with multiple regrowing meningiomas. This one was radiation necrosis, actually, after radiosurgery. She had multiple surgeries, obviously, in this area, and she'd been multiply irradiated there also. And the last thing we wanted to do was stick a laser right through that area. And so it allowed us to pick a novel area that hadn't been opened before as our trajectory to anchor our bolts and place the laser. And so you can see this was us in the operating room, and a very nice response to laser down the line. And similarly with this case, and so it has really allowed me to plan kind of multiple different trajectories, but again, also with positioning to kind of, work out how to place the patient and the lesion in the middle of the bore, as we talked about before. There are still some places that ClearPoint can't go, posterior fossa being usually one of them. There's too much tissue in the posterior fossa for us to screw the base kind of in the midline area here to the skull. But I just wanted to show you that posterior fossa is doable. It just requires for the base to be secured all the way laterally kind of into the inferior temporal area behind the ear. And so it does allow you to get a nice trajectory this way, or even across the cerebellum, as long as your entry is lateral. And so this was a case of recurrent lung cancer. And so what we did was we, the critical portion of the tumor, which was up against the brainstem and the cranial nerves, we used the ClearPoint to get the laser down there to burn this. And then we freehanded the other laser placement because obviously there's a lot more room for error in this region. Obviously, we can do multiple lesions, and so this is a case of bilateral GBM. And so again, we went ahead and planned our best trajectory from a laser standpoint. We then kind of mapped this into ClearPoint, and so this allowed us to plan exactly how the trajectories would come out of the head. And so you see us here in the operating room doing that planning, and then into the bore of the magnet. And so you can see that both of these hopefully should be close to the center of this ring to the best of our ability. And then I think the last example is multiple trajectories for a single lesion. So obviously, as we're starting to laser larger and larger lesions as well. This was a lesion that kind of clearly had kind of bilobed configuration. And so using just one smart frame, we've been able to put in to create two trajectories. And really the way we do that, is if this is the top of the smart frame, what we've been doing is using the XY axis to move the entries away from each other. And so with that, as you plan from say this entry to one target and then this entry to another target, it allows you then to place actually two bolts through the same smart frame that shouldn't intersect with each other. And that allows, and so you don't have to realign with ClearPoint in between. You can just place your two bolts and then you can put the laser down one bolt to burn one trajectory and then just literally place it down the second bolt for your second trajectory. And so it actually makes it quite an efficient use of two trajectories for lasering. And so lastly, but most importantly, if you don't get your trajectory right the first time, I think what's really, really unique to ClearPoint that no other navigation system has is that it allows you to fix your trajectory. And so this is not a tumor case, this is an epilepsy case. But obviously you can see here that at our first attempt, we managed to get into the ventricle and ended up in the anterior temporal horn. And so we were able then to replan, find a new entry point, a new trajectory, and start again and end up in the right place. And so I think for a few cases, this has happened where the first time round, the planning may have not been as perfect as it should have been. And so this really does give you solutions to deal with that. All right. And so I hope that what I've shown you is some of the advantages of using the ClearPoint system in kind of taking care of our brain tumor patients. For me, I think that this coming decade will be about patients surviving a very long time and us dealing with complications or downstream effects of our treatments that were not necessarily meant to last forever. And so I think that what we need to do is work on avoidance of, if we can, but otherwise best management of treatment of complications. And I believe that we've started down that road with ClearPoint to help us with that. And before I end, I just want to acknowledge our team. None of this is possible without an extensive number of people helping me. So very grateful to be part of the team here at Yale. All right, thank you very much.
Thank you, Dr. Chiang. It was a fantastic talk, and I think everybody, I want to offer to the group, to everybody who's on the call, if you go to the Q&A section, you can enter any questions, and we can discuss those. There's a few questions now, and I'll start with the top here. I don't know if Dr. Chiang, if you can see these, but I'll read them out so the broader group can read. First, we have a question. Would you be able to comment on if and how ClearPoint has impacted your practice outside of the surgical suite? Has it, or in, I guess a parallel sort of along with that, has it influenced your tumor board's decision-making and or time to therapy for your patients? So it's kind of a lot packed into that question. I'll let you run with it.
Yeah. So I don't know if ClearPoint has, I don't know that our tumor board per se knows exactly what ClearPoint is. I do know that they certainly have seen an impact from our ability to make small incisions in the scalp to do procedures. They obviously, when these patients come back to the office, there's very much an appreciation for the fact that wound healing has not been a big part of the next steps in their care. And so unfortunately, the ClearPoint part of it is bundled into the laser part of it, which is also minimally invasive. But obviously being able to do this all through a small incision has been noted and appreciated.
Thank you. We have several questions that are more related. It sounds like they're building off the workflow discussion that you had. First one is, what's the maximum number of trajectories you've done for a patient during the same surgery? And then along with that, were you able to mount multiple frames simultaneously, or did you have to move the frame to different entry points? Can you comment on that?
Yeah. So I think the largest number that we've done is just 2 frames. So the base of the smart frame as it currently exists limits how close you can get the 2 together. But yes, we have definitely mounted 2 frames at the same time. Obviously, each one of them still has to be aligned individually. But you're right, it allows, if you do all the steps all together at the same time, it does make for faster. So I think one of the nice things about the planning system is that it does allow you to measure how far apart the 2 entry points are for your trajectories. And so you can then plan before you ever get in whether or not you need to put in 2 trajectories through 1 smart frame, as we talked about, kind of using the XY coordinates to kind of separate your entry points, or if they're far enough apart that you need to mount 2. We've had some interesting cases where, we've literally kind of locked the two together because there's bits that kind of stick out on the sides. And if you can kind of wiggle them together close enough, you know, you can get two frames on relatively close together. Yeah, I think one of the cases I showed, I mean, certainly when they're on opposite sides of the head, you know, that's easy enough. You can certainly mount those at the same time.
Makes sense. Thank you. Okay, the next question is related to the, you had the brief discussion about the posterior fossa and some of the limitations. The question is, I guess specifically, which longer screw options help with that?
So I think the answer is yes. Obviously, it would be nice to have longer screws. I think the issue with the screws currently are that you need to know how far it is from the frame to the bone, because the what's what I'm looking for? The teeth on the screws, they only go a certain distance on the screw. And so it's a little bit hard to judge in the posterior fossa. I think you'd have to work out exactly what the distance is, and then have variable number of screws that are of different lengths. Alternatively, I guess if we had a screw that had you know, the ability to bite into the bone all the way along the screw, then yes, longer screws would be helpful. Yeah, it is a little bit limiting right now. You know, there needs to be solid bone available, and so like I said, the only way I've been able to do the posterior fossa stuff is by anchoring it temporally.
Thank you for that. So we got a few more here, and they're starting to pile up, which is great. There's a question here about software. In addition to the tools that you've highlighted in your talk, are there additional software tools or features which would assist you in your tumor ablation procedures?
I guess I don't really know. We've spent so much time honing down the process between the two. I think we've done a fair amount of software development already. I mean, short of you know, bringing the two softwares together into one seamless you know, process. I'm not really quite sure.
Gotcha. Thank you. It's now jumping to the next one. For this is more just about for training and development for surgical colleagues that are new to the ClearPoint system but are interested. What recommendations do you typically give for them to learn more?
So I think the ClearPoint system is complicated to use. I think that as a surgeon, there are many parts of the software that we don't understand or not trained to do. I think what's really nice is that the system comes with a ClearPoint rep that's irreplaceable. You know, in my operating room, I really can't. So it's interesting that of the two systems, the laser system is the one that that is easier for me to work. And I think the reason is because the ClearPoint system requires talking to the MRI, and there's a lot about that interface that I personally don't know. And so I think that if you're going to start using the ClearPoint system, obviously you want the rep with you. The rep needs to spend some time with your MR technologists to make sure that that the communication is seamless. And then I think it's always worth, obviously there's lots of these videos that are available, but it's always worth, I think, visiting a site that's using it so that you can kind of see the steps in the workflow. It's otherwise there's kind of a lot of trial and error as you get started out.
Thank you. So we've got a reimbursement question. Is there an extra code that can be billed for using ClearPoint in the MRI bore?
Yeah, not that I'm aware of. Yeah, it's the reason why my colleagues give me such a hard time about using the ClearPoint, because it does add extra time for which we are not reimbursed. On the other hand, we do have a magnet that sits completely idle in the operating room if we're not using stuff like this. And so I think the flip side of that is, you know, whatever it costs to get the MR in there, we should be trying to, you know, develop new tools that are better for our patients.
Perfect. Thank you. And then, so sort of switching, I guess, more to the development and sort of opportunities for development. This is more of just a general question. What would you like from ClearPoint that will or could help you treat patients more effectively?
Well, I think I think at the end of the day, development of this of the base and frame, so that they are a little bit either smaller or a little bit less clunky. I don't know if that's the right word. Would be helpful. You know, it's hard for me to talk about the interface with the MRI, but obviously that's a part of the process that takes a long, or can take a long time. And so I don't know if there's some way that that can be made shorter or faster or more automated. Obviously, a lot of my cases challenge those systems because of the trajectories that we choose. And so probably, I imagine for DBS cases, the workflow is simpler. But it'd be nice for the tumor patient to have something that's kind of a little bit faster in the way we get to alignment.
Makes sense. The follow-up to that same question was, and I know you touched on this a little bit on your talk, but are there alternatives to the ClearPoint system from other providers that you might anticipate using over the next, and there's a specific time frame, 6 to 18 months?
No, I mean, I think, as I highlighted in my talk, I think what I like about ClearPoint is its flexibility, and the ability to make corrections on the go. And so a lot of the, I don't think there's any other system that's really out there right now that allows me to do that. And, you know, I think that maximum flexibility allows me to change plan if I need to in the operating room. It also, you know, like I said, I think accuracy has gotten really good. And now that we're comfortable with this, it'd be nice for us to maybe grow these tools a little more instead.
Thank you. Yeah, just that ability to refine in the bore before you've committed that trajectory, I think is at the end, that's the most important. So we have come to the end of the questions. Unless there's anything else, I think we're ready to wrap it up. And again, thank you, Dr. Chiang, for taking your time and presenting and sharing all these details about your practice.